Hi, this is Brian Kim. I'm going to share with you this case of an endonuclear bowlout, and I'm going to discuss why it's so difficult to get these lenses out. Now, as a resident, I remember repeatedly with my attendings telling me, and all of us residents, to watch out for the endonuclear bowlout phenomenon, what we call a nuclear bowlout situation. And why is it? This is a cartoon of the eye. The yellow part, imagine that's the capsule and cortex. The orange part is the epinucleus, and the red part, the central core, is the endonucleus. And remember, the endonucleus is the densest part of the lens. After I do capsulorhexis, you can see the yellow part on the top is gone. You're removing the anterior capsule, which gives you access to the lens material now. And once capsulorhexis is performed, you try to remove all the contents of the lens, which is the endonucleus, epinucleus, and cortex. However, the nuclear bowlout phenomenon, really better to say, call it an endonuclear bowlout phenomenon, is when you have a very thin ring of endonuclear material. So you want to think of it like a stiff onion shell or onion ring that's stiff and it won't collapse. So remember, the diameter of the rhexis is about 5.5 millimeters, and look at the diameter of the endonucleus. It's bigger. And so when you try to grab the epinucleus or the cortex, the lens won't collapse because it's stiff. You want to think of it like a big, stiff plastic ring. And because it's stiff like that, it won't come out. And so what happens? You go after the pieces with high vacuum, and then when you do that and you go deep inside the bag with the high vacuum, you poke a hole in the posterior capsule, you rip a hole in the posterior capsule, and then now you have vitreous loss, lens pieces that are lost, and so you have a serious complication. So this is a case of essentially a nuclear bowlout, and you're going to see how I manage it. So this is a fairly young patient. This patient also has a history of some retinal problems. And you can see the lens looks a little bit different. And as I do the rhexis, you'll see what I mean. And so this is the cotton tip, which is steadying the eye, and then using a corneal marker, which will help me to center and size the rhexis. This patient has a little bit of a Bell's reflex. This is the right eye. Fixating the eye with a cotton tip. And this is my paracentesis incision, first on the right side, and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. Asking the patient to look down, so I have a flat approach, and that's the left paracentesis incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And I'll keep that cannula in there to control the eye, which will help control the Bell's reflex. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel through the cornea, and then when I'm ready to enter, I tilt down and I go in. Keeping that cannula in the eye the whole time, I'm able to control it now for the capsulorhexis. These are my sharp tip Morio microforceps. And if I feel like there's chamber instability, I can always push more viscoelastic if I need to, which I'm doing here. I can sense that the chamber is a little bit unstable. You can see how the bag and the zonules are quite wobbly in this case. As I punctured, you can see the tear went to the left. And so now I'm trying to use the forceps to try to find the edge of the flap. Unfortunately, the flap went down and it's not up, and that's why I'm having trouble grabbing it. I push some more viscoelastic in to see if I can lift the flap. And as I do that, I'm able to grab the edge of the flap here. So as I go ahead and create the flap, you'll see a lot of these tags on the anterior capsule, almost like if this was a pupillary membrane or if it's like pseudoexfoliation fibers or something unusual. As I'm trying to do the rhexis, there's these little fibers that are kind of tethering as I'm trying to complete the rhexis. And I'm not sure if that's a reflection of zonulopathy. You could tell that there's a little bit of zonular laxity in this case, but I'm very carefully going around circumferentially, grabbing, re-grabbing. And for this last part, I push some more viscoelastic in and make sure that the rhexis is complete. Placing some viscoelastic on the conial surface now. So again, a little bit of an unusual lens, shallow chamber, kind of a little bit of a wobbly lens. During the rexus, a little bit of laxity there, and these fine fibers on the anterior lens surface. Burping some viscoelastic out. This is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally. I'm just jiggling a little bit, get a nice little wave, just trying to create a little bit of space with the little jiggling with the cannula. Decompress the bag, just very carefully, making sure that fluid wave is milked all the way around, and now the lens begins to spin. So again, a fairly soft lens, a little bit of zonular laxity, and so you'll see how this ends up as an endonuclear bowl out. I lift the incision with a chopper, go in with irrigation off to minimize decimase trauma. Removing all the surface epinuclear material. Sliding the chopper under the rexus edge contra-incisionally. Turning the phaco tip vertically sub-incisionally. Bringing the instruments together to crush the lens in half. Placing the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip to crush the right heminucleus against the phaco tip like a chopping block. And then using some vacuum to grab the pieces. You can see that the pieces are rather stuck. So I'm using the chopper to go after that first quadrant, lifting it up, grabbing it with some vacuum. But again, it's rather sticky. Even though I lifted it up, it doesn't really want to come out. Lifting another fragment up with the chopper and then emulsifying the lens piece. Going after that fragment again with the chopper, lifting it, trying to get it up out of the bag. Rotating the second quadrant now, separating it from the rest of the lens. Again, using some vacuum to try to grab the lens piece. And again, it doesn't want to come out. Go after the lens piece with the chopper, hooking the peripheral lens, trying to get it up out of the bag. Only having some moderate success getting the lens pieces up. Rotating the lens and the second heminucleus in front of me, placing the chopper on the lens, hooking the peripheral lens, bisecting the lens again with another cross-chop maneuver. Going after the third quadrant, placing the chopper around the lens. Again, rather sticky lens, cheese wiring, somewhat soft, not breaking in the traditional manner. Rotating the lens around the fourth quadrant, popping that fourth quadrant up out of the bag, removing the endonuclear material here. So again, because this patient has a soft lens, a small endonucleus, this is essentially a bowl out situation where I have this super thick epinucleus, probably mixed with some soft endonuclear material as well. And it's because it's so thick, it's keeping that shape, that concave bowl shape within the bag in combination with probably some zonular laxity. Now this lens just doesn't want to come out. And so I'm using the chopper to hook out some of those denser, either they're going to be more central epinuclear material or peripheral endonuclear material, but I'm using the chopper to pull those pieces up. And it's like, like an artichoke or an onion. There are layers to it. And so the layers that are closest to the center are the thickest, more stiff layers. And as you go more peripheral, they become softer. It is a very thick epinuclear / peripheral endonuclear shell. And that's why I think the bowl out is such a difficult situation. Because remember, epinucleus, if you apply vacuum, will just kind of suck out really easily. But when you have a thin layer, like the layers and shells of an onion, the peripheral endonuclear shell material is stiff and it doesn't want to come out. It wants to stay in that bowl configuration. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INE handpiece. I start sub-incisionally peeling from anterior to posterior. And again, you could see how sticky even this cortex is, stuck to the bag, despite good hydrodissection and despite being able to spin the lens. Part of that could be some zonular laxity as well, as I said earlier. But you want to be very careful as you're peeling the cortex. Again, always try to peel from anterior to posterior, which will give you the cleanest removal of the cortex. So when you have the bowl out situation, again, the bowl out occurs because you still have this stiff lens material. It's not just epinucleus, because the epinucleus will just suck out. But you have a thin peripheral bowl of endonucleus. And so that material is what's keeping the lens in that position. And because it's so much bigger than the diameter of the rexus, which is around 5 to 6 millimeters, then obviously it's not going to come out. So in this situation, you saw what I did. rather than going after it with vacuum, which you might end up buzzing a hole in the posterior capsule. That's what we learned in residency. You're not supposed to do that. Using the chopper to manipulate the lens material is not something we also learned in residency. If I tried to do that as a resident, my attending would be like, "What are you doing? What are you doing?" And they'd probably fuss at me, because in a person who's learning, maybe they'll accidentally, rip the zonules, rip the bag, or do something bad. So the point is once you get to a certain level in your career, you need to really learn how to use bimanual surgery. So not just with cataract surgery, but any surgery. Use both hands. Both hands are better than one hand, because you have a lot more flexibility, versatility, and then better control when you're doing surgery. And so in this case, you have that thick endonuclear shell along with the epinuclear shell. I used a chopper to get under the rexus edge, and I was able to pop the lens pieces up out of the bag one by one, and they came up like these tiny little chips, these little sheets, so to speak, of endonuclear material. And as I was able to remove each of those pieces out, I was able to essentially allow the epinucleus to then collapse and come out. And then I was able to finish off the case. And because of the strange behavior of the lens during the rexus, the lens disassembly, I decided, okay, this patient probably has some zonulopathy. I'm going to use the CTR. So you see the CTR is out of the little encasement there. It's sticking up. So I'm able to hook that first eyelet with the hook pointed down, the injector pointed down. I'm able to retract the injector. I like to have it so that it comes out in the clockwise manner. So I hold it in the same orientation, using the Lestro hook to lift the incision, place the injector in, placing the Lestro through my paracentesis incision. As the injector is delivered, I hook the leading eyelet with the Lestro, and as I advance it, the CTR rolls out, but because I'm creating tension on it, it's not putting any peripheral tension on the zonules. And then of course at the end I have to release both eyelets and it goes into the bag. With this technique, I have very good control. I'm able to minimize any torsional stress on the capsular bag. Once the CTR is put in, I fill some more viscoelastic to fill the bag, and then we go ahead and do the sweep. Sweeping on the left side and then on the right side. And this patient is rather young. Again, an unusual behavior to the lens. And so if this patient ends up having a dislocated lens down the road, I'll be able to hook sutures around the CTR and stabilize the lens if the patient develops zonular problems down the road. This is the single piece acrylic lens that's going into the capsular bag. I go in with irrigation off, activate irrigation, get underneath the lens, tilting it and rotating it, removing all the viscoelastic from within the bag, reposit the lens back down, polish under the rexus edge, remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with somewhat of a shallow chamber, fairly younger patient, small eye. This is a high-powered lens with a small eye. During the rexus, I noticed things just behaved a little unusual. I was able to complete it, but I just felt like maybe there was some zonulopathy here. Did the lens disassembly, but the lens basically kind of crumbled. There was an epinuclear and endonuclear bowl-out phenomenon, but using the chopper, I was able to fish out and hook out and remove those thick endonuclear shells. Once the endonuclear shells were peeled out, then the epinucleus was able to come out. And so that's the point. When you try to grab the epinucleus and the endonuclear shells are still there, what happens is you grab the endonucleus with vacuum, and then it slips back into the bag. You grab it in another place, it tries to come up, and then it slips out. Why? Because it's keeping its form. Remember, the lens diameter is like 12 to 13 millimeters, and your rexus is about 5 to 6 millimeters. So unless the lens is willing to collapse, it will not come out. And what's preventing it from collapsing? It's the endonuclear shell. That's what the bowl-out phenomenon essentially is. You have big chunks of peripheral endonuclear material that's acting like this stiff kind of sheet of lens material that is really inflexible. So when you try to grab the lens pieces to come out, they just won't. They'll just be stuck in there. So this is how I handled an endonuclear bowl-out situation, not going after pieces with vacuum per se, but making sure you can hook the thick endonuclear sheets with the chopper, pulling them up out of the bag in order to more effectively manage the endonuclear ball-out situation. So I hope this was helpful to you, and I thank you for your attention.